Good morning and evening, wherever you are in the world, and welcome to the Bonnie J. Adario Lung Cancer Living Room and Patient Educational Series. I'm Bonnie, and thank you for joining us. From our living room to yours. We are all living with lung cancer, and our goal is to bring hope into your home. Empowered patients live longer, and our message is simple. We want you to live.
We're going to start off.
And maybe you can just start by telling everybody that's dialed in hi.
Oh, yeah.
Because there's lots of other patients that have dialed in from all over that are watching you eat right now.
Also, tonight, I know you guys all got my email, and we do have a speaker tonight. So we are going to keep our stories short unless you're new. If you're new, please tell us about your journey. Otherwise, your name, date of diagnosis, stage, and type. And then at the end of the meeting, we can get back to any questions or concerns you may have. You certainly don't have to talk, Esty, if you don't want to. It's up to you. It's up to you. I'm going to pass this around. If you are new, I do, and you haven't, I say this every month, but if you have not received an email from me, it's because I can't read your writing. So just make it as legible as you can. A lot of stuff bounces. Also, if you are new, there is a consent form in the back that I need you to sign. I don't need your firstborn or anything. I just need your signature saying that it's okay that we show you on TV. And that's it. I'm going to hand this to Hugh to start. And then, Kathy, do you want to start?
There's no one new here?
Right.
Can somebody get me a pen?
Poor Kathy, you got her while she was chewing.
Okay. My name is Kathy Parker, and I was diagnosed with stage 1B adenocarcinoma in March of 2011. It still seems like just yesterday, but it's been over a year.
And how are you doing?
I'm great.
Good.
Doing really good.
Hi, I'm Sally. I had put myself in an early lung cancer study and was very fortunate that my lung cancer was found early. And I had my bottom right lobe removed, and it was adenocarcinoma, non-small cell, stage 1A. And I'm doing great.
Oh, you guys have your own. Go. Just hold that for your turn.
Hi, my name is Peter. I'm a tag along because this is my wife. She had the cancer.
Okay.
But tell us who you are, Marge, and
Who are you?
Oh, my name is Marge Pitkin, and I was operated on. It was found, and I guess it must have been the first week, and then by June the 9th, I was operated on, and they removed my right lobe, lower lobe, and I've had no regrets.
I'm Penelope. This is my sister Hannah. We're here for my parents. They're watching us online right now. So February of this year, my mom was diagnosed with stage 4 non-small cell. Found out she had the EGFR mutation. She's been on Tarceva for 2 months. Her first PET scan was 2 weeks ago, and there's no evidence of cancer anywhere else in the body. And her primary tumor has shrunk by 50%. And she's feeling good. So we're all very excited. Thank you.
You're welcome, Penelope. Esty?
she doesn't want to talk.
You want to talk?
Do you want to just say, just for the new people, who you are and...
I'm Nita.
There you go.
I am Dave Palomars, diagnosed with stage 3 mesothelioma in January 2009. I had my right lung removed, pleural lining removed, went through chemo, radiation, and so far all my CT scans are clean, doing well.
Hi, I'm Mary, and I was diagnosed in 2010, October, with stage 4 lung cancer, non-small cell. And I had 13 rounds of chemo and target radiation, and right now I'm not on any medication for cancer.
My name's Elizabeth Lacasia. I'm stage 4. I've had lower left lobe removed. I've gone through a couple rounds of different chemo. I'm currently on a clinical trial of Alimta and Tarceva. I'm no longer on the Alimta, but I'm on I think my 46th round. It has been extremely successful, and I am considered stable and very happy to be that designation.
Leslie, there you go. Scott's going to hand it back to Bill. Sorry.
Hi, this is my first time here. I'm Bill. I have stage 4 lung cancer, and let's see, I was on Tarceva for a couple of months, and it worked brilliantly, and then it stopped. But I've been through carboplatin, and now I'm on maintenance chemotherapy. And this is my mother.
I'm Gail.
Hi, I'm Christy Chappelle. I was diagnosed in late 2009, stage 4 adenocarcinoma, non-small cell lung cancer. And I have been on primarily chemotherapy, some brief stint on Tarceva, but the PET scans show that the disease is moving in the right direction. February was better than November, and May was better than February. And things are getting smaller, and things are getting less active, and I'm feeling quite good.
Hi, my name is Jackie Perkins. This is my first time here. In November of 2010, they saw something on my left lung. And then after a ton of tests last May, I had 5 cyber knives to my left lung. And they took a CT scan in October and said, we're going to have to do chemo. So there were several satellites. And I've been on chemo since November, the carboplatin and Alimta. And nothing much changed, small progression. So I did the Alimta for 2 cycles. Nothing much changed, mild progression. I started Tarceva for a week and found out today my doctor had been to a conference a couple weeks ago in Chicago, and she wants to try me on Taxotere starting next week. So it hasn't spread any more in my body, and there's just mild progression, and I feel good. Thank you.
Jackie, just a quick question. When were you diagnosed?
11/10 originally.
Okay. Okay. You can just hold it, Chrissy. You're good. Yeah.
Okay. My name's Tina, and I was diagnosed with 3B in November of 2010. And today, a year ago, I started my last round of chemo. So I went through chemo and radiation, and my scans since have been no evidence of disease. So just keep on keeping on.
Keep on keeping on.
Hi, my name's Loretta. It's my first time here. I was diagnosed in July of 2011, and I had surgery in on August 17th of 2011. I had BAC cancer, had my right upper lobe removed, and that was all that was necessary for me. And, you know, I haven't missed it a bit. I feel very fortunate to have been diagnosed so early.
That's great.
I'm Laurel. Let's see, I was diagnosed in, I guess, October of 11. And as usual, I let my medical advisor do talking.
Okay. She was diagnosed with fourth-stage non-small cell lung cancer. Went through the infusion therapy for 6 sessions of carboplatin and Alimta, and tried Alimta alone for a couple times, which didn't seem to do much good. And she switched to Tarceva, which she has the right, her mutation for. And she's been on it about either 29 or 30 days now, and we'll know more in another week or so when she gets her first PET scan since she's been on Tarceva.
Awesome.
And I know Laurel has some stuff she wants to talk about at the end. Don't you have some things you want to talk about at the end? Maybe?
Maybe.
Okay.
Does anybody in the back want to talk? No. Yes? No. Okay.
Okay, so Bob from Vancouver was diagnosed in March of 2007 with non-small cell, I'm assuming adeno, Bob? Upper left lobectomy in April. So far, he's totally free and blessed to be here, and he wants to know where the blueberries are. So.
Tell me he has to fly down for blueberries.
Yeah. So what I'm going to do now is, unless anybody has anything they want to add, is I'm going to introduce our speaker tonight. We are so grateful that he has come down to share his expertise with us. It's Dr. Trevor Bavona. He's an MD, PhD up at UCSF. He's a clinician and a researcher. So we love those the most because they see a little bit of everything on both sides. So Trevor, if you'd like to come up. Somebody needs to hand that man a mic, though. And then, Trevor, just so you know, here's your little clicker.
Oh, okay. Thank you.
You're welcome.
Well, thanks to, is this, let's see, can you all hear me, I guess? No.
Talk loud.
Okay.
Okay.
Do I need this?
Yes, you will need it for the people at home.
Okay, so it's really a pleasure to be here. Thank you to Bonnie and everyone in the foundation for inviting me down. It's quite a thrill for me to come down and to meet all of you. You are certainly my inspiration and also our motivation for our research. And what I'd like to do tonight in the next 30 minutes or so is really share with you some of our exciting progress in lung cancer research and how that's really changing the way that that we treat many of you in lung cancer patients. And we really believe, based on the rapid progress and exciting progress we've made, that we're really on the verge here. And so before we get into the slide deck that I prepared, I just want to make one very clear point. And if you take nothing else away from the next 30 minutes of slides, please take away this point, is that we are really on the verge, and I mean this in a very serious way, in a scientific way, of making not just incremental progress in lung cancer research and in lung cancer treatment, but we are on the verge of, because of the exciting science, really curing the majority of patients that we treat. So it's an unbelievable inspiration that so many of you have survived lung cancer here in this room. We think we don't do that enough in the clinic, and we want to make sure that every patient who walks into our lung cancer clinic walks back in 5 and 10 and 15 and 20 years down the road. So in our clinical research and our scientific research, that's our goal. And I can share with you very honestly and in a very real way that we're on the verge of doing that. And so what I'd like to do is to share with you some of the reasons why I think we're on the verge, and share with you a couple of vignettes from scientific research that I think will illustrate that point for you quite clearly. as has already been introduced, so I'm a medical oncologist and have the privilege of caring for lung cancer patients in the clinic at UCSF. And I'm also a scientist and spend actually the majority of my time directing a research laboratory at UCSF that's focused on understanding what really makes lung cancer tick, what causes lung cancer in the first place. And the reason why I decided to devote a large part of my life and my career towards the research component is that I believe that if we understand what makes lung cancer cells tick and what makes them grow and form a tumor, then we can devise better strategies to actually stop that from happening in the first place, or stop it in its tracks once it's already begun to happen. And so what I'll illustrate for you this evening is how not only our research, but research from many other groups around the world are starting to make that happen. And it's really based on a molecular understanding of what drives the growth of lung cancer. So in the next 20, 25 minutes, I've broken up the slide deck into basically 3 parts, and this is rather informal, so please interrupt me, and if I use scientific jargon, and sometimes I do fall into that, please interrupt me and say, hey, I don't understand what that means. Can you please explain it?
Can everyone hear Trevor well?
Okay, I'll speak up a little more. Okay. So the 3 parts of the talk will be just a brief review on how conventionally we think about lung cancer diagnosis and management, and many of you have experienced this firsthand. I'll then move into some of the very exciting topics in current cancer research and medicine in general, and that is how we're using sophisticated genomic technologies to now diagnose and manage lung cancer patients. And EGFR mutations and drugs like erlotinib or Tarceva are prime examples of that. And I know some of you have lung cancers with EGFR mutations and have been on or are currently on erlotinib or Tarceva. And then at the end, I'll share with you some sort of cutting-edge research and what our vision is based on that research of where the lung cancer field is going. And that's where I think we're on the verge of really curing the majority of patients and hopefully all patients that walk into our clinic with lung cancer. And make no mistake about it, and this is often sort of taboo in the scientific world, we are focused like a laser on curing this disease. And so when I give scientific talks around the country, I actually have started to say this, and the first couple of times that I've said it, there were sort of, smirks and gaps in the audience, because lung cancer's been very hard to make significant progress against because it is aggressive, and we have not had a molecular understanding of what causes the growth of lung cancers. But that's changed, and it's rapidly changing even as we speak here tonight. And so we are on the verge of curing this disease. In the majority of patients that we see. So this needs no introduction to this audience, but I did include this slide to make the point that lung cancer is a major public health problem, and lung cancer is the leading cause of cancer death in both men and women around the world. And we are making substantial progress against this disease, but we need to accelerate that progress. And I included these last 2 bullet points in that it turns out that actually more women end up dying of lung cancer than many of these other common cancers that you may hear about, breast or cervix cancer or uterine cancers combined. And more men actually succumb of lung cancer than from prostate or colorectal cancers combined. The reason why I make this point is not to diminish hope that we're making substantial progress against lung cancer, but it's rather to emphasize the point that for a variety of reasons, the lung cancer field has lagged behind, in part because of a lack of research funding, and particularly compared to diseases such as prostate and colon cancers and breast cancer, which have received the lion's share of cancer research funding from both public taxpayer dollars as well as from private foundations. And so that's why foundations like the Unedited Foundation are so critical to raise awareness of the burden of lung cancer and to as well as to help raise research, critical funding that's needed for research to make even more progress against this disease. So what does lung cancer look like? Maybe some of you have seen pictures of lung cancers or seen your CAT scans, which we'll come back to in a minute. But on a very gross level, what lung cancer looks like is this here on the right. So on the left are normal lungs, on the right are lungs with lung cancer. And you can see the sort of blackened areas on the surface of the lungs. Is there a laser pointer in here?
Yep, that's it. I think that's it.
Sorry, okay.
Is it working?
Oh, it's not showing up anyway. But you can see the sort of blackened areas on the surface of the lungs, and those are lung cancer cells growing. Some of the areas are blackened because the lung cancers become necrotic or start to sort of actually outpace their blood supply and start dying. But what's clear is that it looks quite nasty. And in fact, it is a nasty disease, as some of you have experienced and overcome. What does lung cancer look like on an X-ray or a CAT scan? Some of you may have seen some of your own CAT scans or images, but here on the left is a chest X-ray of a lung cancer, and you can see it's denoted there on the left lung as a sort of an inverse or reverse shadow of white marked tumor. In the right is a CAT scan. You can see the cancer a little more clearly. And you can see how the white spaces are growing within this otherwise a blackened cancer-free lung here on the right. And you can see these sort of white nodules scattered throughout the lung. And those are lung cancer cells growing in small tumor nodules. That particular CAT scan comes from a patient with an EGFR mutation, and that patient was treated with erlotinib. And you'll see an image of a different set of CAT scans from that patient and the dramatic response that patient actually had to erlotinib treatment in a few minutes. Another set of imaging in which we use quite readily to diagnose and understand where the lung cancer exists in a patient's body is a PET scan, and that's shown on the right. Some of you may have had PET scans, and I'm sure many of you have. What PET scans do are measure essentially how much glucose or sugar the cancer's eating up. It turns out that cancers eat up a lot more sugar than our normal tissues, and it's because they're sort of rapidly growing and dividing, and so they use that sugar to do that. And we know that cancer cells will take up a sort of radioactively labeled glucose, and so that lights up on this PET scan here on the right. So what you're seeing in this PET scan what you're seeing is a patient with, again, an EGFR mutated lung cancer. So there's an EGFR mutation in this patient's lung cancer. This patient, again, was treated with Tarceva. And you'll see the post-treatment PET scan in a few minutes again. But what you see are the blackened areas in that patient's chest, and that's where the lung cancer resides. And so these imaging tests are a routine part of the way that we identify or define the stage of lung cancer. So when you all were introducing yourselves, I was paying particularly close attention to what to the stage that you all that you all stated you were diagnosed with, and so and the reason why you know that number is because it's actually an important number to know, because it dictates how we approach treating patients with lung cancer.
Can I ask a question?
Yeah.
So what you're talking about, I'm so sorry about the laser not working, but like in the shoulder, for example, is that metastatic disease in the bone, or
yeah,
what is
so
that? Yeah.
Great question. So in this patient, it turns out that this spot up in the left shoulder is a metastatic disease. Although PET scans are a little bit tricky. You need a sort of an expert radiologist to read them, because in joints like the shoulder joint or knee joints, it could be inflammation or arthritis. But in this particular patient, it was cancer. So the cancer here had spread outside the lungs, outside the chest, and in this particular patient, gone to a number of other sites, one of which was that shoulder area. And you can see some uptake in one of the hip joints here as well. And there are a variety of other tests which we won't go into in detail tonight for sake of time, that we use to establish what stage the lung cancer, to examine the extent of disease and use that information to determine what stage the lung cancer is at. So. And this, again, really directs us towards which treatments might be best used to either remove that lung cancer or to shrink it. And that involves different modalities, and many of you have been treated with one or more of them: surgery, radiation, and systemic therapy.
Trevor, what is systemic therapy?
So systemic therapy is therapy that circulates throughout the body and therefore does not attack one particular site of a tumor deposit somewhere, but will attack the cancer no matter where it resides. So if someone is diagnosed with a small tumor and it's in the left lower lobe, I think if I recall, one or more of you had a small localized cancer such as that when we went around the room a few minutes ago. The surgeon can take it out, and the patient can be cured of disease. Now, if the cancer has spread to multiple sites and the surgeon can't take out every site where the disease is, like in this PET scan, like in this patient who underwent a PET scan here, then we need a therapy that can circulate throughout the body and can attack the cancer cells no matter where they are in the body, whether it's that shoulder joint or the hip joint or the chest and the lungs. And so that's systemic therapy. It's generally intravenous, has been conventionally intravenous therapy, and it could be chemotherapy like pemetrexed or cisplatin or carboplatin. And now in the sort of the genomics era, the era of personalized cancer medicine, which is what we'll get into in the second half of the talk, it's commonly a pill that one takes. And so Tarceva is an example of that. Tarceva is a systemic therapy, but it is a pill, but it does circulate throughout the body and attack the cancer cells no matter where they reside in the body. So it is a systemic therapy. And Bonnie's question is actually a nice segue into sort of a summary that I put up on this slide, which gets back to that concept of stage. And so in order to determine what treatment is best for lung cancer patients, we must determine the stage. And so the staging classification is shown here. And in lung cancer, like most other cancers, it runs from stage 1 to stage 4. And what that really indicates is what that really reflects is the extent to which we can find cancer cells or tumors around the body. And so if something is very well confined to the organ, in this case the lung, it's an early stage tumor or a stage 1 tumor. And if the cancer starts to spread outside the lungs, then it progresses to stage 3, stage 2, stage 3, and stage 4. And so in lung cancer, the best chance for cure is a very early stage tumor, a stage 1 or 1A tumor or 1B tumor, where the surgeon can go in and take out the tumor. And as the tumor starts to spread outside the lungs, it either gets bigger or starts to spread outside the lungs, if the surgeon cannot take out the entire tumor in sort of one easy operation or one sometimes complicated but the doable operation, then we start to think about systemic therapy, and there is a chance for cure, but traditionally it has been harder to cure patients once the cancer has spread outside beyond stage 1 and stage 2. And that's sort of reflected here, and we're making, again, dramatic progress in all stages of lung cancer in improving survival for lung cancer patients. But the challenge for the lung cancer field has been, how do we increase cures for patients who present with more advanced stages of lung cancer? And the reason why that's such an important question is that we'd like to identify every patient at the earliest stage possible, but unfortunately that hasn't been possible. And in fact, most patients with lung cancer are diagnosed with advanced stage disease, and so that you can see that sort of in the numbers here on the left, the percent of patients. So 60 to 70% of patients present with a lung cancer that unfortunately the surgeon can't operate on and can't take out, and so those patients are treated with systemic therapy that, while effective and while we're making progress, has not traditionally been able to cure as many patients as we would like. But that's exactly where we're making dramatic progress. It's in those advanced stage cancers, and that's where the field of medicine in general is so excited, and oncology is leading the way, because it's in those advanced stage patients where we're really capitalizing on understanding the biology of the tumor and really carrying out what we call personalized cancer medicine, where we deliver specific targeted therapies that kill the tumor cells, spare normal cells, and cause dramatic responses and benefit for our patients. So, and again, Tarceva is one sort of prime example of that kind of therapy. And one of the cases that I put a couple of case reports in this talk, and so I hesitated a bit to do so because you're all sort of living case reports, and so your stories are much more vivid than a story up on a screen. But I want to share with you a couple of patients that I've cared for in the patients, and I want to do so because they really illustrate what motivates me in the laboratory back at UCSF every day. And so having met you all now, you'll all motivate me every day, but these couple patients have motivated me for the last 5 years or so. And so I actually saw a patient back in Sloan Kettering, which is where I trained in New York, and this patient had presented with a lung cancer. This was a 57-year-old woman and about my mom's age at the time. And she was otherwise quite healthy, and she developed lung cancer and had a biopsy, and that confirmed the lung adenocarcinoma was the histologic subtype that the pathologist diagnosed. That patient was treated with a chemotherapy. Many patients, like many of you, respond well to chemotherapy, and I know many of you are doing quite well on chemotherapy, and that's wonderful. But unfortunately, this patient didn't do so well on chemotherapy. And actually, her cancer was not very responsive to treatment. And she eventually, her cancer eventually progressed, and she unfortunately died of her disease. And so this was about on the verge of a sort of a major break in the lung cancer field in the mid-2000s. And that is really that we've now begun to understand that lung cancer is not one disease. In fact, lung adenocarcinoma, which is one subtype of lung cancer, is not even one disease. And that understanding has dramatically changed the way we treat patients. But in 2004, that wasn't really the case at the time. And so, what we thought at that time was that all lung cancers were pretty much the same. Sure, we could name them adenocarcinoma, and we knew there were some differences between adenocarcinoma and other subtypes like squamous carcinoma. We'll come back to that in a minute. These are what the cells look like under the microscope. It's a pathologic diagnosis. So the pathologist looks at that biopsy or that tumor resection and says, that looks like adenocarcinoma, that looks like squamous carcinoma, but it really doesn't tell us much about the biology of the disease. And so we thought basically all patients with lung adenocarcinoma were pretty much the same. That's the sort of the circle here. That's pretty monotonous and uniform. And so they were all patients with lung adenocarcinoma were primarily treated the same with chemotherapy. And sure, we could vary the couple of drugs we gave based on side effects and what we think might work a little better in some patients than others. But unfortunately, over the last 30 years or so, that really hasn't gotten us very far, because it turns out that because we did not understand much about the biology of the disease, and we weren't able to specifically tailor our therapies to attack that biology and to capitalize on the knowledge of that biology, the survival rates for most lung cancer patients have lagged behind some other cancers. And this just sort of reflects that point and drives that point home even further, and that this is coming back to that circle of lung cancer and in an era of where we're now moving out of, called depersonalized cancer medicine, in that we thought that all lung adenocarcinoma patients were pretty much the same, and they got the same treatment. Same for squamous cell cancer patients. So if you had a lung cancer that the pathologist said was squamous cell carcinoma, you got some different drugs, but it was pretty much dealer's choice by the oncologist. One of the things that motivated me to go into the lung cancer field was seeing this patient in the clinic and realizing that we just weren't doing enough to understand the biology of the disease, and that's why I thought, and others as well, thought that perhaps our treatments were not as effective as we would like them to be.
Just real quick, because I know that my mom was diagnosed in 2003.
Yeah.
And what was available in as far as therapies then versus what maybe is available now are two completely different dynamics.
Absolutely,
right?
And that's the point.
Amazing. That's the point.
That's a great point. So,
Yeah.
and the point, and that's the point we're going to spend the rest of the talk on.
Yeah.
But the field of lung cancer has changed quite dramatically, and because of the rapid progress of research, we have many more therapies available today, and we've now moved past this hurdle and are really on the verge again of making a substantial impact in this disease and curing most patients that we see in the clinic.
And could I just throw something in, Trevor?
Yeah.
The reason this is so good to hear all tonight, because I, like you, when I was diagnosed, we all hit the internet. And there was no good news on the internet. And there really still is no good news on the internet. So the point that I think Trevor is going to make tonight is This was 2004. We're now in 2012, and it's a completely different place. And it's a good place, and it's a place of hope.
So, and that's a great point, Bonnie. And I'm going to spend the majority of the rest of the time on that. But I thought it was important to give you sort of a perspective of where we've been in the lung cancer field, and sort of where we are now. And I think that by doing that, it'll illustrate for you the sort of the exciting, unbelievable progress that we're making, and also illustrate the point that we're really on the verge of taking it right, actually, sort of almost to the end zone, to use a football analogy. And so I'm going to get to the era that we're in now, which is this exciting personalized cancer medicine era. But I want to leave you just with a couple of pictures of what these cancer cells actually look like under a microscope, because you may not have seen that before. And so I'll spare you the Google search. And so here's the so here's what a pathologist sees when they get a biopsy, some of your biopsies, for example, or a surgical tumor specimen from a surgery. So this is what a lung adenocarcinoma looks like. So what you're looking at is a tumor stain for the cancer cells, and the cancer cells are in the middle there, and there's a sort of a reaction around the cancer cells going on, an immune and inflammatory reaction. The body's trying to react against the cancer, but you can see that the cells are quite angry and are rapidly dividing, and how you can tell that is the very dark sort of spots in that circle, which are the nuclei of the cancer cells. There are too many there. That should be essentially an empty circle with a few cells scattered around the outside. So cancer's uncontrolled growth, and that picture illustrates that. The same for squamous cell cancer. It looks a little different under the microscope, and that's why the pathologist is able to say it's squamous versus adenocarcinoma. But this is what a squamous cell cancer looks like, and it has a different morphology or different appearance of the cells, and so you can see them in the pink area there cascading about. They don't belong there. So what I want to spend the rest of the time on now is having illustrated for you sort of where we've been in lung cancer. I now want to take the time, as Bonnie emphasized, and share with you where we are and where we're going, which is what I love to talk about, and why I was thrilled to get the invitation to come down and spend time with you tonight. So we are now firmly in an era of personalized cancer medicine and personalized medicine in general. There's been a movement in the sort of the post-genome era that many of you are probably aware of, having living in the Bay Area and Silicon Valley and reading the New York Times and Wall Street Journal, that we are now in the genomics era. So everyone's asking, well, where can I get my genome sequenced? And so in oncology, I think we are capitalizing on genomic technologies and examining genomes in a way that is leading the field in medicine in general. And so that has ushered in a new era in medicine that is termed the personalized medicine era. So what is personalized medicine? So personalized medicine is really tailoring the way that you diagnose or treat a patient's disease based on what the specific cause is in a particular patient. So what I'll illustrate for you in a few minutes, and I've already alluded to, is that in the case of lung cancer, what causes the growth of one person's lung cancer is not the same as what causes the growth of another person's lung cancer. And so it's actually illogical to think that you could treat those two patients the same. It's a simple logic problem. There's actually no science involved in that reasoning, right? And so personalized cancer medicine is really all about figuring out what are the molecular abnormalities, the molecular changes that make a lung cancer cell, and figuring out how to interfere with that process. And again, a paradigm of that, and a prime example, is EGFR mutations in lung cancer and drugs that are molecules and therapies that act against that EGFR mutation. And one of them is Tarceva. And I've just put up a definition. I basically just stated this, so personalized medicine is really all about targeted therapy. Targeted in the sense that it's targeting that specific alteration in the tumor cell that makes a patient's cancer grow. Personalized lung cancer medicine is really molecularly tailored therapy that acts against cancer-specific dependencies driving tumor growth in an individual patient. So let me come back to that cancer-specific dependency. So what that means is that therapies are less toxic. Because what a cancer-specific dependency means is that the tumor cell is dependent on that mutation or that change in a way, because it specifically occurs in the cancer cell. It does not occur in your skin cells or your hair cells or your colon cells. So the implication is that, well, if you develop a drug that blocks that cancer-specific change, then it should only affect the cancer cells. It shouldn't affect your hair cells or your skin cells or your colon cells, and so you should not get a lot of side effects from that treatment, because the treatment should be specifically attacking the cancer cell in a way that is almost an Achilles heel of the tumor. And so that is really what molecularly targeted therapies like Tarceva are doing. That's how they work. But as you can see, now, before we can develop a targeted therapy, we have to know what we're targeting. And so that's why it's essential to figure out what are the molecular changes that make that lung cancer cell a lung cancer cell. And so this is, I just included a web shot of a New York Times page from Friday. So this has been all over the lay press, and it's exciting for us as scientists and oncologists to see, because this is, oncology is really leading the way here, again, in moving scientific discoveries and personalized medicine forward in our society in general. And so this is from the New York Times research page from a few months ago. And illustrated there is another PET scan. You'll probably recognize the image. This happens to be a patient with melanoma, and this patient's melanoma had a gene mutation, which also, by the way, it happens to be a gene mutation that can occur in some lung cancer patients. We won't discuss that in detail tonight. But you'll see the PET scan on the right looks quite different from the PET scan on the left, and that's because that patient was treated with a drug that targets that mutation. So it's a Tarceva-like drug, except for a different gene mutation in melanoma patients. And so, so these are the kinds of headlines that you may have been reading. A roller coaster chase for a cure. After a long fight, drug gives sudden reprieve. So this illustrates for you just how promising and how exciting this is. I mean, this is front page New York Times. Yeah.
Mary, can you grab a mic? I'm sorry.
The gene mutation, the cancer cell is producing that, or I don't quite understand.
Yeah. So I'm glad you asked. So what's special about these mutations in a gene like EGFR that you're referring to is that it only occurs in the cancer cell. So it doesn't occur in the normal cells in your body. And so that allows us to make a very specific targeted therapy that acts against the cancer cell. Because we can make a drug that blocks that mutation in EGFR that will only have effects in the cancer cell.
Okay, thank you.
And that can change as your cancer is there. And I'm sure Trevor will talk about that.
So we're now firmly in the era of personalized medicine in treating patients in a very sophisticated molecular way, as I mentioned. And as evidenced by that, there have been a number of therapies since, in fact, 2000, a little before 2004 in other diseases, but the sort of early to mid 2000s, as Bonnie indicated, was heralded sort of a new era in oncology and in medicine. And so some of the FDA approved, so frontline standard of care therapies that are now on the market for lung cancer patients are shown here. One of them we've talked about extensively already tonight, the drug called Tarceva that I know some of you have been on and are currently on. Another drug was approved just recently for another mutation in lung cancer, a mutation in a gene called ALK. And it's a bit of alphabet soup, so I'll try to keep the acronyms to a minimum. But what's important is that if a patient has a lung cancer that has this ALK gene mutation, again, it's only in the cancer cells, then it turns out that we now know that a drug that blocks that ALK mutation is very effective, and it's now the standard of care for those lung cancer patients. It's called crizotinib or Xalkori. It's shown there on the bottom left. So Tarceva is in the middle, Xalkori or crizotinib is on the bottom left. So these are therapies that are now on the market for lung cancer patients that were not on the market just several years ago. In fact, Xalkori is one of the fastest drugs through the FDA approval process in the history of medicine. And so the discovery of that ALK gene mutation in lung cancers happened only about 4 or 5 years ago. So this drug is approved now. And that may sound slow to those of you not in medicine or science, but that's very fast. And it's getting faster. In fact, we're approving drugs in the targeted therapy area faster. And the reason is because we're not fishing around for whether a drug will work or not. We know where it should work because we've identified what is the sort of specific Achilles heel or sensitivity to that drug, either an EGFR mutation or that ALK mutation or others. And so it's actually, so our ability to understand the biology of the tumor is actually making it more, is actually streamlining the process to develop effective therapies. And that's what's so exciting and why we're making such rapid progress, as Bonnie alluded to. So, and here are some pictures of some other targeted therapies and other diseases besides lung cancer. I don't want to, this isn't to, this is not, I don't want to leave you with the thought that those are the only 2 targeted therapies in lung cancer. There are many more in the pipeline that will be approved shortly. But I wanted to illustrate for you some of the other drugs that you may have seen in the lay literature. So there's a breast cancer drug called Herceptin. That was one of the first targeted therapies to be approved. There's a drug called Gleevec up on the upper left. That's essentially changed the natural history of a disease called CML. It's a kind of leukemia. CML about 15 years ago was a universally lethal disease. No one survived CML. They often got a bone marrow transplant, which is a pretty harsh therapy to go through. Today, virtually all patients who are diagnosed with CML get that drug, and they live an almost normal life expectancy. So that has single-handedly transformed that disease. And the same is true for many of these therapies. Now, this is a drug that I mentioned. You saw the PET scan on the New York Times page that I mentioned, that melanoma gene mutation. So just so you've heard the name, or in case you may come across this, this is the drug that targets that mutation in melanoma. It's called Zelboraf. This was approved also last year. So again, I mean, this is sort of hot off the press kind of stuff. And this drug is now being tested in lung cancer patients because, as I mentioned or alluded to a few minutes ago, it turns out that same gene mutation that can happen in melanoma can also happen in lung cancer patients. And so here's an example where progress in the molecular understanding of one disease accelerated our ability to treat patients with a different disease, lung cancer. And it really illustrates the power of understanding the molecular changes, these gene mutations, these alterations in cancer cells, because it allows us to synergize amongst different cancers. And so here's an example where this is an already approved drug. So you can do this trial today without having to go through any sort of experimental process of developing the drug in the first place. And those trials are now ongoing in lung cancer patients. So.
And how it shows how important it is that you have molecular testing. Absolutely. Because you can be tested for these other mutations as well. And it's just amazingly exciting.
So that's a great point, Bonnie. So, implicit in all this, and Bonnie brings up a great point, and actually it's a good opportunity to drive this point home, is that, again, remember, in order for us to treat patients with these very specific smart drugs, essentially, we've got to know which patient is the right patient to put them in. So if a patient has an EGFR mutation, I wouldn't treat them with a drug that doesn't hit that mutation. It doesn't act against that mutation, like Zelboraf. I want to treat them with Tarceva, but that's all predicated on first looking in the tumor and finding those mutations in the first place. And so that is now becoming, and this needs to be more widespread in the United States and around the world. But there's been a sea change. This is changing rapidly. What's necessary is that when a patient with lung cancer is diagnosed, their tumor sample is profiled for these molecular changes. So we can say this patient has an EGFR mutation, this patient has a ALK mutation, this patient has a BRAF mutation, that's the melanoma and lung cancer gene. So that's now becoming a part of a standard workup for a lung cancer patient, in the same way that a chest x-ray or a CAT scan or a routine blood test has become is part of the standard workup. Those imaging studies that many of you have had and that I shared with you in the beginning. The reason why this is possible is because of the rapid evolution and progress we've made in the ability to sequence genomes, human genome, cancer genomes, corn genomes, whatever genome, at a very sort of, at a relatively low cost. And the cost of sequencing, which is a sophisticated technology, is coming down. And so one can sequence a genome of someone for a few $1,000s now, and that'll be that's rapidly plummeting. These tests will be available routinely in any hospital around the world because they will be no more expensive than an MRI or a CAT scan.
Terry needs a mic. Sorry, nobody at home is going to be able to hear.
This is actually a question from my daughter who's watching, but she wants to know, with regard to the percentage of people that are tested with the ALK mutation, how what's the percentage that the crizotinib, I can never pronounce it, is working, and for how long is it working?
It's a good question. I'm actually going to come back to that in a couple slides. This will give me a chance to reinforce it when I come back to it. So to answer the question, it works in the majority of patients. So, excuse me, if there's an ALK mutation identified, I should be specific. In case you guys are on the web or reading, or it's actually a little bit of a different mutation than the EGFR mutation. It's actually a rearrangement of two genes. So it turns out that this ALK gene gets put together or fused with a gene that shouldn't belong there. And so it's actually called a gene rearrangement or a gene fusion. So the response rates in patients with that gene fusion with ALK to crizotinib, that drawing on the lower left, are higher than, are certainly the majority of patients. I think the clinical studies are sort of ongoing at this point, but we know from early studies anywhere between 50 and 70% initially. Patients who are on therapy who have a response, some do quite well for many, many months, in some cases years. Many patients, however, do progress. Their cancer does outsmart the treatment. And so while patients experience quite dramatic benefit, there is this problem of drug resistance that we're actively researching and trying to overcome. And I'll touch on that. That's actually a major focus of our research at UCSF. And I'll come back to that. I'll come back to your question with some data slides in a few minutes. So coming back to the concept of identifying these gene alterations in cancer cells, this has been now a major effort of the medical community in oncology specifically. In fact, your taxpayer dollars are paying for this right now as we speak, whether you know it or not. So we feel an obligation, of course, to deliver on that taxpayer dollar, my taxpayer dollars too. One of the major efforts to sequence the genome of every cancer, not just lung cancer, but all cancers, is ongoing now. And there's been some quite exciting data that's come out of that very recently. And I just threw up a slide here to illustrate that project for you. It's called the Cancer Genome Atlas Project. So it's essentially just mapping the changes in lung cancers at scale. So several hundred lung cancers are being examined. And what we're looking for in this project is cancer-specific alterations that don't happen in normal cells, but that happen specifically in the cancer cells. So we need more. We need to identify more alterations like that EGFR alteration or that ALK alteration or that BRAF alteration. And hopefully it's clear to you why we need to do that. It's because we can then develop smart drugs that act against those mutations. And so that's how we're making progress against this disease. But this is a major effort of the government and consortium around the world. And it's called the Cancer Genome Atlas Project. So what has this project yielded? Well, so some of what it's yielded is shown here. Some of the, and so these are, again, coming back to those two sort of pie charts, which you'll notice are not now empty circles, but they're actually pieces of pie. Now we know from cancer sequencing studies, from looking at the genomes of cancer cells and looking for specific mutations and alterations, that, for example, lung adenocarcinoma shown up on the left, remember that was sort of an empty circle a few slides ago? Well, that's what it looks like today. We now know that lung adenocarcinoma is not one disease. It's a spectrum of diseases. We don't know the entire spectrum yet, but through efforts like the Cancer Genome Atlas Project, we will know every mutation in every lung cancer in a short period of time. So shown up there are a couple of the mutations that the names and the alphabet soup that we've been talking about already tonight. About 15 to 30% of patients with lung adenocarcinoma have a mutation in that EGFR gene, so that's shown in the red piece of pie there. There's that BRAF gene showing up. That's the melanoma gene. It's altered in lung cancer too. And there's that ALK fusion that I mentioned a few minutes ago. And so the rest of the names we don't have to go through in detail. I'm happy to talk this to anyone who's interested later or take questions on them. But these are specific molecular alterations in genes that occur specifically in these lung cancer cells. And so the same is true for squamous cell cancer. Remember I showed you that these are two sort of histologic subtypes, so these are cancers that look different under the microscope. Well, they also look different when we look in their genomes. When we open the book and read their genome, they look differently. And so these are some of the gene names, and again, it's not terribly important for tonight's purposes, but see, these are some of the gene names that we've been able to find are changed or mutated in squamous cell lung cancers. And so this has now led to the development of clinical trials that test specific smart drugs that act against these specific mutations. So that FGFR1 gene is a good example of that. There are clinical trials ongoing now as we speak around the world that are testing drugs that act against that FGFR1 gene. Those drugs don't act against EGFR or BRAF or that KRAS gene, KRAS. They act against the FGFR gene. And so the early data from those clinical trials and others testing these targeted therapies is very exciting and very promising. And so that's why so this is the kind of information and data that allows me to stand up here and say that we are on the verge of curing this disease, because now we're understanding for the first time in history what's causing the growth of these cancers in a very sophisticated way. And so this has led to, this is really what personalized cancer medicine is all about. It's identifying which patients have which mutation and matching up the drug that specifically acts against that mutation.
Mike.
Liz,
Mike.
you need a mic.
Sorry. Just a question to clarify. When you're looking at this wheel, for instance, under lung adenocarcinoma, a person may have a combination of those mutations, right? But there are certain mutations like KRAS versus EGFR. It's very unlikely that you have both, but you could have like an EGFR and a ROS1 fusion or things like that. So people could have several of these. It's not that a person has one, their cancer is only an EGFR sensitive cancer.
It's a great question. So in some cases, we know that these mutations, these sort of famous or celebrity genes that we now have all become very familiar with, don't occur with another famous mutation. In some cases, they do. So you've hit a couple of, so you've touched on a couple of subsets in which you can find co-occurring mutations. But one example that you alluded to was that, for example, we know that EGFR and KRAS mutations are exclusive, so those don't occur together. But we do know some cancers that have, we've identified some cancers that have both an EGFR and PIK3CA mutation, for example, and so in the blue, and there are numerous examples where we do see multiple alterations, and so although I think that so. In the case of EGFR and BRAF and ALK and these major drivers, it has not been the rule; it's been the exception. But I would say it's an area of active research as to how to approach treating those patients. And so it might be that we need to target multiple mutations in a patient if those mutations are identified. And so that's very much where we are. That's very much the third part of the talk, which is moving towards sort of smart cocktails of drugs that attack maybe not just one mutation, but more than one if necessary. But that's where we are. That's the sort of bleeding edge. This is now sort of standard of care. So, but next frontier is identifying which mutations can co-occur together, and which ones we should be targeting together with combinations of drugs. So that's an area of active area of our research, actually.
Trevor, can you talk a little bit about how one mutation disappears and another one appears?
Is that the bleeding edge portion of the conversation?
Am I jumping? Am I going too fast?
No, I think we're just about segueing into that anyway.
But before you go there, can I, in talking with patients sort of all over the country and really the world, several of them run into sort of roadblocks, if you will, with their own physicians in regards to the molecular testing in general.
Mm-hmm.
Is there anything you can say to the people in the room who might have, come across those stumbling blocks, and or the people online who might be watching, or the people who will watch it in the future, as to how to talk to their doctors about why this is so important? Because not everybody has a benefit of seeing someone like you or someone like-minded who just automatically does this.
It's a great question. First, I think that we, as an academic community and researchers, do need to do a better job of disseminating this information to oncologists in the community and and around the country who aren't at sort of major centers or major hubs like San Francisco or Boston or New York, that is an active area for us and academics, as well as organizations like ASCO and AACR and others. So. We hope that'll improve. And here, yeah.
Right, we might be
But I mean, my point is, even major organizations where, every oncologist goes to ASCO, right? I mean, everyone just goes there. It's like a pilgrimage every year. And so ASCO has recognized that and made it sort of a major, item on the agenda every year. And so, but we need to do a better job of that.
But I know that even with some of the patients that I talk to, and when I give them, please go back to your doctor and talk to them about, and they're still telling me no.
Okay. So I can't speak to any it's sort of hard to speak without specifics, but of a particular. But there should be, if you have an advanced stage lung cancer, there should be no reason not to profile your tumor for these gene mutations. And so, which ones do you profile for could be a matter of debate amongst your doctor and experts. We at UCSF and academic centers like the Dana-Farber Cancer Institute, MD Anderson, Memorial Sloan Kettering, and several others around the world, we strongly advocate and have an infrastructure in place to profile tumors for these mutations. And we think it's very important because it's not for just research purposes, and although it has the dual role of enabling research that will improve things in the future, but it can actually change the way that we treat the patient undergoing testing. And so, and that's particularly relevant in the setting of even drug resistance, where patients, for example, on Tarceva, and this is what we'll get into in the last part of the talk here, who often experience dramatic response, feel better. Many patients go on for months and years, but many patients don't, and their cancers outsmarts the Tarceva. And we think it's critical at that point to say, okay, wait a minute, the drug stopped working. It should be working. It stopped working. Let's figure out why before we have a knee-jerk reaction to just dump something into a patient that there's no biologic rationale to do. So we actually advocate for even biopsying a patient for profiling not just before therapy, but actually during therapy, and especially in the setting of resistance, to figure out what's causing that resistance. And it turns out that we can actually identify molecular changes in that resistance, in that tumor that developed resistance to the drug, that will allow us to direct a second smart drug at the tumor. So we are working with a couple of community groups to try to sort of emphasize this. But it is a paradigm shift for oncologists. I mean, the traditional teaching. I'm pretty young oncologist, but even at Memorial where I trained, where there are some very it's brilliant people, but there are some traditionally trained oncologists. I mean, it took a real sea change there to get older oncologists to advocate for profiling and rebiopsying patients. So we do need a bigger effort in that regard. I should also say that if anyone is having trouble or feels uncomfortable and that their local oncologist will not profile a tumor, there are certainly avenues to do so, and we are one at UCSF. There are other avenues as well, but we have a very active program at UCSF in profiling tumors, and so my point is we're happy to help in that regard as well, as are other centers around the country that are local for patients who are not here tonight.
To point anybody who might be watching online in the direction of a place that will
for
do
a
it.
second opinion, so you get to a place that is offering this kind of profile.
Absolutely, and just to be very granular about why should you get biopsied or rebiopsied, because it can identify a mutation, like these mutations, for which you should get a drug, either upfront, and that's becoming more routine, profiling for EGFR mutations and ALK mutations, et cetera. But specifically when, if unfortunately that targeted therapy does stop working. And so it can direct a patient to, for example, a clinical trial of an exciting drug like that Zalbiraf drug that was approved in melanoma. And so just as one example, but there are many examples where we could say, okay, you live in Virginia, you go to a local academic center and get your tumor profiled, and then at least you're presented with a portfolio of treatment options, some of which may include smart drugs that are these targeted therapies. And so we think it's very important no matter where you live.
Where does one go to when the Tarceva no longer works and seemingly regular chemotherapy drugs? I don't know if this works or not.
Okay, it does.
Regular chemotherapy drugs don't work at all. Tarceva works beautifully, but now the Tarceva, in my case, has stopped working.
Okay.
So where does one go to search next? I mean, as an
see me.
individual.
Or people like me, or groups like. So the so in your specific, obviously I can't give you medical advice because I don't know your case, and it would be irresponsible for me to do that. But if the Tarceva has stopped working, what we would advocate for is a resampling of a tumor in a safe and hopefully painless way. Oftentimes it's a small biopsy, and then sampling for a gene mutation that will allow us to present you with a rational
we've done
option.
all of that,
Okay,
and
great.
there's no ALK, and there's none of those BRAF or any of that other stuff there. It's just the EGFR mutation, so far as we can see from the sample that we did. And I'm aware that another part of the sample, that wasn't taken might exhibit this.
Right.
But it's hard as a patient to, consider all of this, to consider all the clinical trials that are going on, and so few of them, because as each person is individually different and has had different treatment to date, it's difficult to find someone who's doing what I am a patient is interested in. Making myself clear.
Yeah, no, I understand you, and I empathize with you. So we have found that if you look broadly enough, in other words, you look at enough. So in some cases, you get what you get what you're looking for. So if you're not looking for the needle in the haystack, you might not find it. So we advocate for as broad a profiling as possible, and so that may be looking not at 5 genes, but at hundreds. And so I don't know the specifics about your case, but it may be that on a broader sequencing platform that looks at hundreds of genes for mutations that have drugs that act against them, that we would be able to identify something. Undoubtedly, there is something causing the growth of your tumor. That's the only thing I can say for certain. It's a matter of finding what it is, and so it might be that the technology that's been used, has not been able to identify that, but that's a technological limitation that we could overcome. If you're, I'm happy to talk to you, in detail afterwards.
Thank you.
Trevor, there's a patient online in Michigan who's currently NED, diagnosed in 2008, stage 4 non-small cell adeno. She's in a phase 2 clinical trial with Gemzar Avastin. She had a needle biopsy in one of her lymph nodes, but nothing that they can use. If she wanted molecular testing done, does she need another biopsy?
So the challenge with molecular testing is that depending on the test that you use, it can require a good amount of material. But we have routinely been able to do this from needle-sized biopsies. So again, I don't know the specifics of the biopsy here, but it probably depends on whose hands that material winds up in and what assays run. But from the rebiopsy protocols that we're involved with often use a needle biopsy done in interventional radiology. So it's not a surgery; it's a same-day procedure, and it's certainly certainly not trivial. I mean, I haven't gone through it, so I certainly, don't want to minimize it. It is a procedure, but it's pretty well tolerated, and the specimens are not extremely large. And so, what's quite exciting is that the sequencing technologies, again, have advanced so rapidly that we need less and less material to get more and more information out. It may be challenging, but I would be surprised if there was not sufficient material to do some profiling on that kind of specimen.
Trevor, is it possible that you start with an EGFR mutation and then you become resistant, but after a time, you might be able to go back on Tarceva because the resistance is no longer there?
So that's a great question. So so this is now the third part of the talk. So we'll skip the slides and just keep talking because you're asking all the questions. No, it's fine. No, I'd rather not. It's better as a conversation. So you're getting into some sort of cutting edge, sort of research areas, and so there is no, I don't think, you may have three folks like myself get up and give you three different answers here. Maybe not, depending on who you call. But we do know that what tumors are sort of a collection of cancer cells that may have sort of a spectrum of mutations. So this was alluded to by what was your name? Elizabeth a few minutes ago, asking about, well, are there multiple mutations in a tumor? How do we know which ones to treat? And so now we're getting into sort of, the research, the cutting edge research in the field. It turns out that, so we think now of a tumor as sort of in a very evolutionary kind of way, a Darwinian sort of way, where you've got a big, sort of chunk of tumor. Within that tumor lives a variety of sort of smaller tumors or clones that may have sort of different molecular abnormalities. That if we sample the tumor and we identify an EGFR mutation, that may be from one part of the tumor, one clone, but there may be other ones in there that we didn't sample, right? The Tarceva is given. It causes a tumor regression, but what happens? Well, in a Darwinian way, or sort of, if you think about this as in evolution, the tumor says, okay, well, that clone you've suppressed, I'll figure out how to get around that drug. But in the meantime, those other cancer cells that maybe don't have that mutation or are less dependent on that mutation actually start to grow out. And so that's how you can get regrowth in some cases. Now, it turns out that, so that's good news and bad news. It turns out that the good news is that oftentimes when that's the case, what that means is that the patient may need to stay on that therapy because those other clones can be then targeted with second drugs. But you need to keep that Tarceva pressure on the tumor to keep that original sort of dominant clone at bay. But we also know what Bonnie is alluding to is that it turns out that resistance to Tarceva can also manifest as sort of a more indolent tumor growth. So when that cancer progresses, in some cases, it's actually less aggressive. So from a teleologic sort of standpoint, what might that be? Well, the tumor is sacrificing fitness. So it's saying, okay, well, I'll grow a little slower, but at least you're not going to kill me with that Tarceva. I mean, so we try to, so this is sort of, in the laboratory, we try to get in the tumor's head, so to speak. And so that's how, we rationalize some of the observations that we see. But so the punchline in sort of simple terms from a clinical standpoint is what we may be doing, what we may have to do in the clinic in moving this forward is analogous to in some ways to the HIV paradigm. So I'm not sure if, and that's actually going to be the last slide, but so I'll come back to this in a few minutes, I guess, as we're wrapping up. But I'm not sure if you're all familiar with how HIV is treated today. I don't treat HIV patients, but I did as a resident. But the way HIV is treated is not with one drug, but with a cocktail of drugs, and the cocktail of drugs hits multiple aspects of the virus of HIV. And so when HIV patients were treated with one drug, what happened was the virus mutated and it changed and it developed resistance, and so that's kind of what we're talking about with cancer here, right? What folks did in the HIV research community is rapidly figure out what causes that resistance, what are the molecular changes that drive that resistance, and then how can we bring in a second or a third or a fourth smart drug to develop sort of a smart cocktail therapy. And actually that's how HIV patients are treated. It's called HAART, Highly Active Antiretroviral Therapy, HAART. And it's a cocktail of 3, 4, sometimes 5 drugs, depending on the patient and the kind of virus. So that's where we're going in lung cancer research. It's figuring out, which combinations of drugs should be used in which patient, and so that's where the sort of bleeding edge is in personalized cancer medicine and lung cancer research, and that's what's going to get us to chronic disease and cure. So HIV and you all know this better than I do because I'm pretty young, but HIV, I remember growing up, was a lethal disease. I mean, it was a lethal disease. And today, I have a picture. I'm going to give away my last slide, but of Magic Johnson. I mean, he just bought the Dodgers, right? So he was diagnosed in like 84, 85. And so it really illustrates how understanding the molecular alterations that drive the pathogenesis of a disease, how understanding that can allow us to develop smart therapies to really transform the natural history of that disease, from lethal to chronic and essentially into we hope even a curative mode. So I can come back to that. So this was a. So I want to sort of, I'm not sure how much time we have, so I wanted to sort of
You've
move.
got time. You have all the time you need.
Okay, so I thought I'd just show you a little bit of, in sort of very oversimplified graphic terms. We've been talking about mutation and identifying mutations that cause cancer growth, and so I wanted to just sort of, picture's worth 1,000 words, and maybe an animation is worth 5,000 words. So this is an animation that we've been using in our lung cancer program as we go around and talk to folks, and some folks find it helpful. So what you see up there on the left is a CAT scan of a patient. There's lung cancer there circled, the white blob, and so this patient had an EGFR mutation. And so what does that really mean? So what happens in the cell? And so what happens is that EGFR mutation actually activates a number of events in that cell to make it cancer. I mean, so this is in some ways looking under the hood now at what an EGFR mutated lung cancer is. And so what you're looking at there, those circles with squiggly lines, is actually the outer membrane of a cell. And so that's would be the cancer cell. On that outer surface of the cancer cell is that protein EGFR. It sits on the outer surface, and its job is to tell cells when to grow and divide. And that's how your skin cells divide. It's called epidermal growth factor receptor. You may realize that the epidermis is the outer layer of your skin. So this is an essential protein. The problem is that in these what happens in cancer is that this cell acquires a mutation, that EGFR mutation. So there's an L858R that some of you may have seen on your pathology reports. There's a couple other major mutations, an exon 19 deletion. These are just molecular terms for the kind of alteration that happens in this EGFR gene that makes it not normal. And so, and what happens is this mutation causes that receptor on the cell surface of an epithelial cell in the lung to become active, hyperactive, too active. And it doesn't know when to stop activating those events that tell the cell to grow and divide. And so these circles here are other proteins in cells that regulate how cells grow and divide. And so you can think of it in some ways, it's not a perfect analogy, but like a gas pedal on a car. The mutation is just slamming the gas down, and so the engine is in many ways all these sort of events, these proteins in the cell that just start going, and the wheels start turning, and before you know it, you're going 100 miles an hour. And so, and that's essentially what happens in these EGFR mutated tumor cells, and that's also what happens in ALK mutated cancer cells or BRAF mutated cancer cells. Now it happens in different ways. Some of the names of the players inside the cell changes, but and so what are we doing when we treat with Tarceva, or erlotinib is the sort of chemical name? What we do with erlotinib is we reverse that process. So it blocks the activity of that mutated gene, that EGFR gene, and it shuts off that whole cascade of events that's happening in the cancer cell. So it's almost like applying the brakes. And so, but what's special about these gene mutations is it's not just like applying the brakes, it's actually like delivering a sledgehammer. And so what happens in this cancer cell is it actually doesn't just stop growing, it actually dies. And so that gets back to that dependency word I used a few slides ago. So this mutated gene called EGFR actually creates this dependent state. The tumor cell is addicted to it. It's an addiction. Because when you take it away with that drug Tarceva, it dies. So it can't live without it. That's addiction. So And our research program is focused on understanding the molecular basis for that addiction. Because understanding how that tumor cell becomes addicted to that mutation allows us then to develop smart ways to block that from happening. So there are drugs in development in the clinic in patients right now that act against not just EGFR, but many of the players inside the cell. And so as we now get back to that concept of combining treatments, so what drugs can we give in combination with that Tarceva treatment? It might be that in some cases we give drugs that really demolish or block the activity of some of these players that act what's called downstream of EGFR, so that carry out the nasty function of EGFR inside the cell. This comes. I was just going to again focus on EGFR-mutated lung cancer for a bit in wrapping this up, and because it has led the way in this and provided really inspiration for all of oncology and for personalized medicine and targeted therapy. And so this is actually a study published in one of the famous medical journals called the New England Journal of Medicine. This is by one of my close collaborators, Rafael Rosell, in Spain, and so this is one of the first clinical studies to demonstrate that routinely examining a lung cancer for an EGFR mutation actually matters, is important, and should be done. And so that comes back to the point that questions many of you have raised, and Bonnie's point. This should be routine in lung cancer, in the analysis and the workup of a lung cancer patient. And so Raphael's study was one of the first to show that. This illustrates the hope of doing that. So why should we be doing this sophisticated molecular testing? Well, we've already said this ad nauseum tonight, and I think you all are believers in this, but just to drive the point home from some data, identifying the patients with that EGFR gene mutation means we can treat them more effectively. And here's the data that prove that. So this is a bar graph, and so what's shown here on the y-axis is overall survival of patients and with lung cancer, and on the x-axis are different ways that we've treated lung cancer patients over the last 30 or more years, 1976. That's when I was born. So what you see is that, interestingly, so this is why there's so much hope, as Bonnie alluded to, and what I hope is the major message from my talk here, is that although the progress against lung cancer had sort of lagged behind some other cancers or many other cancers for years, almost 30 years, we're now making substantial and rapid progress. So from 2006, and we could even go back probably to 2003 or 4, as Bonnie alluded to now, and this is a little bit of an older view now, so it looks even better in 2012, trust me. Look at the progress we've been making in improving survival for all lung cancer patients. And so this is quite dramatic and rapid progress in just a few short years. And what you'll notice is that the treatments are changing. So you'll notice that gefitinib drug listed there, and erlotinib against Tarceva. Gefitinib is sort of another kind of erlotinib. It's called Iressa. It's used around the world. And it acts the same way that Tarceva does. And so we're really making dramatic progress as a result of matching our treatment, i.e. putting the Tarceva into patients who have that specific EGFR gene mutation. So this makes sense to do. It makes sense to identify which patients have the mutation, and it makes sense to treat them accordingly. And so this is some of the data that prove it. And this is just one. This is one of many.
That's William Powell's slide from Vanderbilt.
Yeah. So this is William's slide. So William has been a leader in the identification of EGFR gene mutations. William and I became friends at Memorial, and he is now at Vanderbilt and leads and has really done some spectacular work on making this type of genetic and genomic information accessible and meaningful to patients. And there's actually I could do a little advertising for William. I don't know if he's watching, probably not. But there's actually a website that is quite useful and called My Cancer Genome. And so William was recruited to Vanderbilt from Memorial in part to sort of build out the personalized medicine program there, and he's done a spectacular job. And that's a very useful website I think for patients. I find it useful myself to use. So it's called My Cancer Genome. I think if you Google it, you'll find it.
You can find it on Vanderbilt website.
Erlotinib is Tarceva. What is gefitinib?
Good question. It's Iressa. Yeah. So it's one of the. It is just not in the United States, and it's for a sort of a technical reason. But it works very similar to Tarceva. They're essentially interchangeable. It turns out that when the early clinical studies were being done, there were different doses used, and so for more practical and technical reasons, Iressa is currently not FDA approved in the United States. But patients here get treated with Tarceva, but that's not the case around the world. But yeah,
We actually have a patient. His name is Wells Whitney. He's been on Iressa for 13 years.
Oh, wow.
Stage 4
Okay.
lung cancer.
That's amazing. Wow.
Yeah.
That's great. So what I wanted to do, I guess, sort of at the, I guess I'll sort of skip through a few slides because what I wanted to was to sort of come back now and finish. We've already talked about sort of the cutting and bleeding edge, but really describe to you where the research is, where it's going, and where the field is going now. And so we are firmly in the genomic era of lung cancer research and oncology in general. We're firmly in the targeted therapy era. Hopefully that's become apparent to you tonight. But where are we going, and how are we going to cure even more patients than we're curing now? Because that's what we'd like to do ultimately, and that's our goal. And so, and that will require even a deeper understanding of tumors at the genomic level. So profiling for mutations at a deep level, and that'll require matching smart drugs to those mutations, and it will do so. It will require doing so in a cocktail-like fashion, so that we can either overcome resistance that's developed, or preferably, and this is an active area of our research, preventing that resistance from happening in the first place. I mean, the best way to overcome resistance is to prevent it from happening in the first place, right? So the idea here is is that we need to move into sort of the HIV paradigm, where we come up with a cocktail therapy or multiple cocktail therapies that would be given to a patient based on profiling their tumor up front in the initial setting, the first time you come to clinic. And that then you would stay on that therapy for years, like an HIV patient does, for years. And so ultimately, we'd like the tumor to completely go away, and that would be a cure, and that's our goal. But in the context of HIV, what's become the paradigm is chronic disease, and certainly we would like we would take as a start chronic disease for most lung cancer patients. And so, but we will not stop there. Our ultimate goal is to cure. And the harder we can hit the tumor in the beginning, we think the better chance that we can cure every lung cancer patient that walks in the door. And so, and we have evidence from our own research that actually might be the case. And so I won't go into all of the details of our research tonight, but I'll hit on one or two small findings that we've had recently that suggest to me that we actually might be able to hit the tumor so hard in the beginning that it never has a chance to develop resistance in the first place. Not with one drug, but with multiple drugs. And so, let me go back to. And so, so here's sort of the idea. The idea here is that we're now in the era of what we call genomics-driven treatment. So genomics meaning profiling tumors for mutations, and that drives the way we treat patients. So genomics-driven treatment of lung cancer patients. And that what we'd like to do is to not only come up with a targeted drug number one, we're pretty good at doing that now. We've got Tarceva, we've got crizotinib, we've got several of these other targeted therapies emerging and soon to be FDA approved. But what we need to do is really to come up with drugs that can overcome and prevent that resistance from happening. So the top three, this is a complicated slide, so we'll go through this in little bites, and I'll spare many of the details. But what we'd like to do is to really stop those three PET scans from happening. So we'd like to sort of stop, at the middle PET scan and subvert resistance altogether, so that patients don't come back with a PET scan on the right. The way that'll happen, the way that it's happening now, and what we're doing in our laboratory is more comprehensively profiling tumors. And so this is just some fancy colors and schematics here to illustrate that. But this this rectangle with blues and reds and whites is an example of some data from profiling a tumor. And so each of those spots is a gene, and the colors there indicate some of the alterations that happen in the tumors. And so, so we can analyze elements of tumor cells, the genome, the DNA in a tumor cell, for mutations in any gene in the genome. And then through a sophisticated sort of interpretation, analysis, and study that we're able to do, in not just in our laboratory at UCSF, but at other places like at Vanderbilt, for example, and Williams Group there, and in other institutions, we're able to really figure out, well, what are the important alterations and what are the less important alterations. And why that's important is we want to be matching drugs up to the most important mutations. And so that's actually quite difficult and challenging information to glean from these large data sets, but it's tractable. And that's what we do. And that allows us then to come in with a targeted drug either initially, and this has been the case for Tarceva, for example. But let's say you don't have an EGFR mutation or an ALK mutation or a mutation in BRAF or other famous genes that we know about. We'd like to begin to identify a gene mutation in every patient that walks in the door, such that we can match up a targeted therapy to that patient. And so this has become now a sort of a systematic pipeline that many groups around the country have established to routinely profile tumors both before treatment and then after treatment. This comes back to Bonnie's point about biopsies and what we call serial biopsies. So taking samples of the tumor in a safe and hopefully relatively painless way, so that we can really analyze the tumors at multiple points during therapy. That will allow us to intervene and add a second drug or a third drug if necessary to prevent or overcome that resistance. So I think I've lost a slide. Maybe it's my laptop or. But we're just about done in any event. Oh, maybe not. Okay. And again, to drive the point home, what we like to do is to use this complex analysis of tumor specimens from patients in a clinically meaningful way, and that is to say, to develop more rational, biologically based treatments for every patient. And allowing us to do that, I don't know what I did.
There you go.
Oops. Allowing us to do that, and we have evidence from our laboratory studies that this will actually be the case, allowing us to analyze those tumors really enables us to prevent resistance from happening altogether. And so what we envision, again, is sorry for this, I don't know why this is happening, is an upfront personal targeted drug cocktail that would be safe and well tolerated and act specifically against the changes in those cancer cells to subvert resistance from happening altogether. And so some of our research in the laboratory has identified some resistance mechanisms in EGFR mutant lung cancer patients, and so we've published our findings, and so a couple of the sort of the headlines of those papers are shown here. So one paper we published last year on a pathway called the NF-kappa B pathway. Again, it's alphabet soup, I know, and I apologize, but we discovered that this is a pathway that, when active in those lung cancer cells with an EGFR mutation, can cause resistance to Tarceva. And so now we're doing clinical trials to test whether drugs that block that NF-kappa B pathway can prevent that resistance to Tarceva from happening. And so that would be an example of, again, that drug cocktail. So should we be combining Tarceva with a drug that hits that NF-kappa B pathway? It's a combination, a cocktail therapy. And those are clinical trials that are happening this year. And a second, more recent discovery that we've made is that is in that setting of resistance, so after initial response, so when a patient gets Tarceva, does well, the tumor responds, and then unfortunately starts to outsmart the Tarceva and regrow, we and others have identified some of the mechanisms by which that occurs. And so one mechanism we've recently discovered is in a gene, again, I'll mention it, but I'm not going to quiz you on it later, of course. It's a gene called AXL, AXL, and what this does, what happens here is that in the setting of Tarceva resistance in an EGFR mutant lung cancer patient, this gene takes over and says, okay, fine, well, you've blocked that EGFR gene, but that drug isn't working against me, and the me here is this AXL gene. And so that's good and bad news, right? So the good news is that this happens in the setting of Tarceva resistance, and we don't like to see that. But the good news here is, and the hope here is that, well, what makes this incredibly exciting is that there are a lot of drugs that act against this AXL gene. So we will move very rapidly to clinical trials testing these drugs in patients. In fact, one of the reasons why UCSF is such a special place to be as a researcher is that some of the drugs were actually sitting on the shelf of a chemist one floor above my head in Genentech Hall at UCSF. So, and these are quite potent and good drugs, and they're working in our laboratory models, and so we're able to actually overcome Tarceva resistance in the models in which we discovered this AXL gene as a cause of resistance by using these inhibitors of this AXL gene. So we are very focused again like a laser on bringing that to the clinic, and that would be again a combination therapy that would be rational based on the biology, what's causing tumor growth in the setting of resistance. And we're quite excited about that. And I'll leave you with the last slide, which is I guess I stole my own thunder, or maybe Bonnie did, I don't know. But it was Magic Johnson and HIV. So the HIV field, and there are other examples of this too, but is really provides, I think, inspiration for us in the cancer field. We think cancer is a little more complicated than HIV, but that's okay. We're a lot of smart people working on cancer, so we're ready for the challenge. And so we think that by devising rational cocktail therapies or combination therapies that act against the specific molecular drivers of the lung cancer and growth, that we can transform lung cancer to a universally chronic and curable disease. And so that's where the field is now in research, and that's where we're going. There hopefully will be a celebrity who is diagnosed with lung cancer on the cover of Time magazine, and 20 years from now, some young oncologist will be saying, "Yeah, we already did that," and so they'll be talking about the next challenge in oncology. But could be somebody in this room, sure.
Right, or out there watching.
So I think this, sorry for, I guess I went on and on about this,
No.
but happy to
You have a
take any
question?
questions or.
Oh, here. Oh. Our mic guy is texting.
I was just wondering if you have any thoughts on lung cancer as far as being hereditary, and if you have any thoughts on if you're seeing that trend in your family on any screening for early detection.
Yeah, that's a great question. So we know that there are some mutations in the germline, in other words, passed from generation to generation, that can occur in lung cancer patients. That's very rare. And in general, that's not the case. For example, these EGFR mutations, rarely, if ever, is there a mutation that gets passed on. These are chance events that happen in the tumor cells that you don't pass on, in the germline or to children in the family. Now, there are some families where lung cancer seems to sort of run in the family. So that could be for epidemiologic reasons or environmental exposure reasons. So was it a household of smoking or tobacco use, and was everyone around that? Or it could be that there are genetic changes that are in the germline that are passed through generations. We don't have a good sense for how frequent that is in those particular families, but we will soon because of the genomic profiling that's going on. So there are studies doing whole genome analysis, so looking at the entire genome of a patient, not just in the cancer cell, but actually the DNA that wires your entire existence. And so that would tell us whether there are mutations that we've missed. An example of that from the breast cancer field is the BRCA or BRCA mutations. We haven't found that in lung cancer, but we may if we look hard enough. Not BRCA specifically, but other genes.
You found HER2 though in lung, right?
HER2, so HER2 is mutated in lung, yeah.
Right, and that
absolutely.
is a breast cancer mutation.
Yes.
Yes.
Yes, absolutely. But the question was specifically about germline or hereditary mutations, and so.
I thought someone who was here previously said that people with the EGFR, that they were going to do a sputum test to see.
You're talking about the T790.
No, that's T790.
Oh.
Yeah, that's different.
Okay.
Can I ask a question? And, it sort of is tagging on to her question. So my mother passed away of lung cancer 12 years ago.
Okay.
And I was diagnosed stage 1B and I'm EGFR positive.
Okay.
So it's just, it's kind of interesting. I don't know if my mother had the EGFR. Thank you. So now, of course, I'm worried for my daughter. She's 35 years old.
Okay, yeah.
So you're saying that the EGFR, you don't think that gets passed on?
Well, so there are data that have looked at this, and in general, it is not passed on. So it's not high. It's not a mutation that we see routinely that's passed on. There have been a couple of sporadic reports. So I could not rule it out. For example, in your family's case, what's equally as likely in those situations, or in your situation, is that there's a mutation in another gene that actually regulates is sort of a safeguard gene or a watchdog gene. We through sunlight and other environmental exposures, smoke, smog, whatever, we're constantly exposed to mutagens or things in the environment that can cause these changes in DNA. But our bodies have adapted to that, and we actually have a system in place in our cells that recognizes those changes and fixes them. But in some, in some people, some of the molecular components of that safeguard system, are impaired or don't function as well. And so it could be, and I think it's probably equally as likely, that there may be alterations in a gene that fixes those mutations when they happen. We know that this happens routinely in some families with syndromes in which cancer is diagnosed very young, sometimes in childhood. Your family obviously doesn't have one of those syndromes, but we don't have enough information to go looking for a gene, say, in your family today with regard to that.
Do you have enough information? And I don't want to put you on the spot, but to know when our children should be tested, or if they should, like my daughter at 35, would that be even recommended?
I understand your concern, but based on the data, we can't recommend any specific test at this point. Yeah.
Somebody on the line wants to know if there are different mutations for smokers versus non-smokers.
Good question. So the answer is that. The answer is that in smokers, there tends to be an enrichment of some mutations, and in people who have not smoked very much, never smokers or non-smokers or light smokers who've had have had some exposure but not a lot of exposure to cigarettes, there can be different mutations. But I say that with hesitation, because we actually know that here molecular biology trumps that. So, and what I mean by that is that we do see patients who've smoked that have an EGFR mutation. EGFR mutations are mostly found in patients who haven't smoked very much or at all. But if a patient comes into clinic and they say, I've smoked, it does not mean that we don't test for an EGFR mutation, because it can occur in smokers, for example. So we believe in molecular testing, whether you're a smoker or not.
Perfect. Somebody else online wants to know real quick what your thoughts are on Avastin.
I don't have many, to be honest. But so I'm a very honest guy. So Avastin can be very useful as an adjunctive therapy in combination with chemo in many cancers, lung cancer included. I think that some of the original data in other cancers like breast cancer and colon cancer that seemed to indicate that Avastin would be quite a useful therapy have not borne out in additional studies. So I think certainly there's a place for Avastin in the treatment of lung cancer patients primarily as an adjunctive therapy in combination with chemotherapy.
Another patient online wants to know if you see a lot or a correlation between lung cancer patients that also develop type 2 diabetes. Is there any link?
So there have been some epidemiologic associations looking at tens of thousands of patients. The hypothesis is that there may be sort of an inflammatory. We know that there's an inflammatory contribution to the growth of many cancers, lung cancer included, and we know that patients with diabetes do have an underlying inflammatory state, so a hyperactivation of inflammation essentially. There's been no molecular correlation, so there is a epidemiologic correlation, but we really don't know what to make of that. There's no causation that we can prove based on the available data.
Back in Michigan again, just a comment. She says that this is wonderful information given in a way that she's been able to understand, and has given her very important questions that she can now take back to her oncologist. So thank you.
You're welcome. Thank you.
Somebody wants a recap of Bonnie's story, but we all know how long that takes. That's Heather in New Jersey.
Tell her to email me.
So that's, yeah, email Bonnie, Heather. I think I'm good here. Oh, I think I know what the answer to this is. But some patients want to know if they can have copies of your slides.
I'm happy to share some of them. Yeah, a couple of them are I can't share for confidentiality reasons.
So maybe
some of
what
the
you
data
can do is
slides,
send me a deck
but
that
I can certainly
share.
send. Yeah, absolutely.
Okay.
So I should say, so what I certainly take more questions, but I wanted to, I do have one more slide that I must show, and I must acknowledge sort of our research group at UCSF.
I don't know why that keeps going
and
I'm sorry.
Yeah, it must be. Maybe if I keep doing this or something. Sorry, but so I want to just acknowledge our research group at UCSF, both in my laboratory as well as in the thoracic oncology program at UCSF, and
You're on again.
and so. No, it's plugged in. But and so some of the lab members who've contributed to the research that I described very briefly to you are shown up to the left. And this is our laboratory. You're welcome to come visit anytime. We can show you around. In fact, Bill in the audience I think is coming on Thursday with some of his family. And I also have to acknowledge some of our funding sources here, which includes some private lung cancer foundations, and that funding is essential to our work. In addition to the government, we are funded by your taxpayer dollars, so thank you to all of you. And I do want to also acknowledge the folks at UCSF who've been extremely warm in welcoming me to the community over the last year. I moved here almost a year ago now to help build and improve the lung cancer program, which is already spectacular, but to make it even stronger. And so I wanted to thank David Jablons and in surgery and Eric Small in medicine. I also wanted to thank Van and Eddie Van Auken, who were a big part of my arrival at UCSF, and they're not here tonight, but it's been a pleasure to get to know them a bit over the years, and I know Bonnie's a close friend of theirs, and I wanted to thank Bonnie and the foundation for also warmly welcoming me to the community here in the Bay Area. So, I just wanted to certainly make those acknowledgments. So I'm happy to go back to taking questions.
When I was diagnosed in the first part of the year of 2011, they didn't do a biopsy because they were worried about the danger of it because of where the tumor was.
Okay.
And they tried to avoid that. So I didn't have one, and in May I had the CyberKnife, and then in October it turned out things had spread. So I haven't had biopsy. Mm-hmm. Should I insist? From somebody? Or?
I would say that if I was and how are you being treated right now, or you're not having treatment?
I'm on chemo now.
You're on chemo, okay.
After the CyberKnife.
Okay.
Many satellites appeared.
Okay, and there's been no molecular analysis of the tumor at this point. No. Okay. So I can't tell you what to do. What I can tell you is what I would do if I were your oncologist. I would biopsy and profile your tumor for mutations. That would allow me to. I can tell you what I would do as your oncologist. One of the things I would do is to arrange for a biopsy of your tumor, and to perform molecular studies on it, looking for EGFR and other mutations.
I have a couple questions. The first one is does your lab publicize or put on your website which combination of mutations that you found could be a combination? Because this is the first time that I've heard. Most of the time they've been telling us that usually if you have one mutation, you can't have another one. But where can we find which ones have been found in combination?
Right. So, good question. One of the things I should, one caveat and one caution is that, we do need to do clinical studies to prove that targeting these mutations in these cocktail therapies are effective. The way to find out about this is to come see us at UCSF. That's one way. We publish all of our findings, so they're all peer-reviewed and out in the medical literature. But the clinical trials that will test these, whether targeting multiple mutations is more effective than targeting one mutation, which we predict based on the data, we will be doing at UCSF and other institutions. So, if you're in the area and this is of interest to you, then I would suggest, coming to our program and meeting with us, as part of your sort of treatment evaluation and workup.
Well, and then my second question is with the targeted therapy, they're taken by a pill through the mouth. Have there been any clinical studies shown that what happens if you take this targeted therapy through the vein, like say an antibiotic, sometimes they give it to you through the vein to make it act stronger?
Yeah. So I hope I didn't leave you with this impression, but not all targeted therapies are by pill. Many are, and of course, when drug developers make a targeted therapy, they hope to make a pill because it's just obviously easier to take than getting an intravenous therapy. But some are not, and so in fact, one of the drugs in one of our cocktails happens to be right now at least an intravenous therapy. So although it is targeted at a specific alteration, so not all are pills, but I think as more of these target therapies emerge, drug companies clearly recognize that taking a pill is much more convenient. The issue is that these drugs, you need to develop a pill that has the appropriate chemistry to deliver the drug at a high enough dose to the sites of interest and to the cancer cells. And so it's harder to do through a pill and through the GI tract, but it's a problem that the pharmaceutical industry is quite good at overcoming. So.
I actually have two questions. One is from Bob in Vancouver. He apparently he has a question regarding CT versus PET scans, and now that he's post-diagnosis, he was wondering his doctor's only having him do CT scans now versus PET scans, and he was wondering whether he should be more adamant about asking for PET scans or CT scans, how often, how many, and also is it important to have bone scans? And also I'm personally interested in that too. So. Okay,
all good questions. I would say that which scan you go with is in part sort of the choice of the treating oncologist. Most patients who present to our center, all patients who present to our center with advanced disease get a PET scan. It often can be done in combination with a CT scan so that you can reduce inconvenience for the patient. What we recommend is that if a patient comes, for example, to us from and is being treated elsewhere, and they've had CAT scans all along, and they're here for a second opinion, for example, we recommend just being consistent. So if you've had CT scans, then continue to have CT scans. There's no reason necessarily to switch to a PET CT arbitrarily for no specific reason. There are no data comparing, clinical trial data that directly compare whether PET CTs or CT scans are more useful or lead to better outcomes in lung cancer patients. In other diseases, that has been shown to be the case, but not in lung cancer. But we do think that it's important to be consistent. So it's important not to switch back and forth between a CT and a PET scan because they do reveal different information, and it's hard to sort of keep track of the cancer if you're not using a consistent method to analyze the tumors. Let's see, the intervals. It's periodic, and it's at the discretion of the oncologist. It sort of depends on the nature of the tumor growth or the response, or where the patient is in their sort of therapeutic journey. Without specifics, I couldn't make any specific recommendations on the duration or the interval for CT scans in this case. Bone scans certainly have a place. Certainly, they're useful if there's suggestion on an imaging study that there may be an area of metastatic disease. So, for example, on that PET CT, where we saw that activity in the shoulder joint, it might be useful to get a bone scan and kind of correlate there. It's not a scan that's routinely used in the workup of advanced stage lung cancer patients, but it's one that's available, and would not be wrong to get a bone scan. But if the patient hasn't had one in the beginning, and there's no concern for bone disease, no pain, no questionable spots on another imaging study, then there would be no reason to get a bone scan, without those specific concerns.
Super, great. The second question I had was actually more of a. Can you hear?
Yeah.
Oh, okay. Sorry.
I thought the voice was coming from over there, so I love it.
Oh, okay. Well, this actually,
You're throwing your voice.
this question is actually from me. That was
Okay.
from Bob from Vancouver. So I'm kind of ponying up. I just wanted to say, in relation to the question that Bonnie posed earlier about why should patients get molecular and genetic testing, and I just wanted to give kind of an insight from the patient's perspective, because I was diagnosed in 2008. And molecular and genetic testing was not done routinely at that time at all. And when I went through and I had surgery and had my lower left lobe removed, and 18 months later it came back, and they immediately launched into having me, once they re-diagnosed it, that it had indeed progressed and it had spread to all my lung lobes, so I was stage 4 at that point. They started me immediately on essentially a trifecta cocktail of carboplatin, Gemzar, and Avastin. And they didn't do molecular genetic testing only after I had a second opinion from another doctor. Oncologist, did they strongly recommend doing molecular and genetic testing? And from my personal experience, I am a strong believer in molecular and genetic testing, because if they had done molecular and genetic testing before I had done that trifecta, they would have found out that my cancer was resistant to the most toxic of the chemos, and so essentially it wasn't even working. And they would have made a different cocktail for me going forward. And even though my molecular and genetic testing at that time, it wasn't as comprehensive as it certainly is now, they certainly knew more about my disease simply by knowing the things that it didn't respond to, as well as the things that it was resistant to. So they knew more about my disease by doing the molecular and genetic testing. So for those patients that are out there and wondering whether they should go to the doctor and really push for this, if their doctor's reluctant to do it, I say a hearty heck yeah, because as far as I'm concerned, more information is always better than less. So that's just I'll get off my soapbox now, but from my personal experience, that's why I believe in it. So.
I have a question about, my wife went through chemo, radiation, and has taken Tarceva for several months. And for the last 3 and the 4th scan being our results tomorrow, that she's been very clear, no problem. So how do you make the decision as to whether you continue the Tarceva or not?
In this case, it sounds like an easy decision. If it's working, you continue it. So that's sort of a no-brainer, and that's great to hear. I'm very happy for your wife. In patients who, in whom the Tarceva stops working, some oncologists stop the drug and some continue it. And that in part depends on, whether the oncologist is rebiopsying the tumor, whether it's reanalyzed, and but certainly if it's working in this setting, without any question of whether the tumor is developing resistance at this point, then you certainly continue it. It's sort of indefinite.
It kind of all boils down to the side effects. She wants her hair to grow out normally.
Okay.
She looks like Halle Berry. It's crazy.
So,
I mean, seriously though, the side effects are not a big issue with her, but with some people they are.
Sure, absolutely.
And if you are successful and you have, are not having cancer, then can you stop taking it?
Well, so
should you stop taking it?
It's a great question. So what we do know is that If you remove if you stop taking Tarceva, there is a chance that the tumor cells that are left behind will start to grow again, and it could be that in the absence of the drug, they grow faster than they would have normally. So we would not advocate for, certainly for stopping the drug, it is, the side effects, certainly no one minimizes the side effects, but anything that you do in medicine is a cost-benefit analysis, and you never want to harm a patient. But here we think that in this, the kind of context, that the benefits dramatically outweigh the risks. I mean, it's easy for us to say, we're not the one dealing with the side effects, but it's, it's our job to keep you alive and to keep the cancer at bay, and the best way we can do that is by keeping the Tarceva on board.
And on the other hand, there's some that say that if you keep taking it, you can develop a resistance, right? That it doesn't work. And so then if it doesn't work, then if you stop taking it and then take it later, it will work. But it's like a flipping a coin or something. It's like
there is a chance, and this was sort of part of what we discussed tonight. An ongoing area of research is that the tumor could develop resistance. But Bonnie alluded to someone with the foundation or who's been on Tarceva or Ressa for 13 years, right? So that could be you.
Right.
I have a question. A real short one. Does Tarceva cause hair loss?
It can cause hair thinning. Certainly, yeah. Generally not the profound hair loss that, you never say absolutely not in medicine or science, because there's always a case you can find that it happens. But it certainly does not cause the hair loss of that you think of with old-fashioned chemotherapy. It's generally some thinning of the hair, and certainly change in the texture or in color sometimes.
So, as much as I would love to sit here and let you all ask Dr. Bavona questions for the next 4 hours,
which you would do,
I'm going to, unless anybody has something they absolutely have to ask right this minute, I'm going to go ahead and say thank you to Dr. Bavona. Very, very much for coming. I know, I'm sure I'll get a ton of feedback from you guys that I promise I will forward to him. Seriously, thank you very much for coming.
It's been a pleasure. Thank you for inviting me. It's been a pleasure to be here, and it's been one of the highlights of my year in San Francisco, being here tonight with you all. And I would like to leave you with one, with one message also. It's that please reach out to me or to us at UCSF. We are very happy to help you in any way we can, whether it's advice, whether it's seeing you in consultation, whether it's treating you, or whether you just like to come by and see our laboratory. Our doors are wide open. So, so please contact me or a program at UCSF, and I can leave. Do we have information for? Mm-hmm. Or to leave you with my email address?
We know
got
where
it
to
all.
find you.
I know where you are. Yeah.
If you Google me, you'll find me too.
And to Trevor's point, I hope by having Trevor here and other doctors that have come in and spoken as well, it kind of removes some of the mystique about what happens when you go to the doctor's office. Because what I have found in my journey, they're just real people that want to make a difference and they want to help you. They're not entities that you need to be fearful of. So Trevor means it. Go see him. Go see his lab. He'll take care of you. Thank you.
Thank you all. There's more food. Help yourself. And thank you to everybody who, I don't even know if we're still live or not, but thank you to everybody who clicked in tonight. I hope you enjoyed the show.
And let us know.
Wave to the rest of the world. Oh, yeah. Everybody wave at cameras.
Everybody, thank you.